We've known each other in lots of different ways, and I consider you're one of the most brilliant writers in the world. You're one of the most brilliant data scientists. I don't know how the government persuaded you to come in. So what was the big offer they made to you?
There's a crisis. It's a crisis. Oh, is the mic on? There's a crisis. It's an opportunity as well. And for me, my entire career, my writing, my public health work, my career as a surgeon, has been about how do we make sure we have health equity, by which I mean we have enabled an 80-plus year life expectancy if you can get access to the public health services and the core healthcare delivery capabilities that we've created in the last century. Only a part of our population, even in the US, gets to have that life expectancy. Enabling that capability to go to every person in the world, town by town, to every person alive, is the job of our generation. And this crisis has made incredibly clear, the COVID crisis, that it's not enough to have the breakthrough innovations, we have to have the follow-through innovation. And this is a team at USAID. I get to lead 2,500 people, $7 billion in deploying capability around the world.
So I'm going to tell the audience, I'm going to overstate something for effect. I'm not sure I believe what I'm about to say, but I want to use it as a way to raise a point. I used to be a trade policy wonk many years ago, and doing trade policy used to sort of ask, okay, if we really wanted to achieve outcomes in labor and environmental issues, you would negotiate differently than we were. And so my question to you, and it's a serious one, if we really wanted to change global health outcomes, and we wanted to take seriously the fact that my health is connected to a person in Sri Lanka's health, what would we be negotiating for that we're not doing today?
Well, first of all, you got to understand, global health is one of the few examples where human beings have come together and made steady, year-by-year progress. The exception has been the last 2 years. This is the first reduction in global life expectancy.
We've gone backwards.
We've gone backwards. First reduction in global life expectancy in more than a century. And only a part of it has been directly because of COVID. COVID hit the lowest income parts of the world, the poorest 2 billion, because their health systems then also were harmed along the way, because the economies fell through and they didn't have the buffers we'd had, because food prices skyrocketed. All of those things meant that the majority of the deaths have been in children under 5, women in childbirth, and the broader health system and the issues there. So as we take on, I mean, we have 2 core issues then where we have to act differently. Number one, we've gotten through 3 of the 4 quarters in this football game, and we can't give up the game now on COVID, right? That at the center of it, we still have surges that will come. In places like the United States, we now have the tools, thanks to teams like Dr. Fauci's, who have given us vaccines, but also rapid diagnostic tests, antiviral pills that are 90% effective, even if you aren't vaccinated, and addressing high-risk people to disconnect the cases from the deaths so far. Those rapid diagnostic tests for people in most of sub-Saharan Africa, for example, in Haiti and other parts of the world, those, let alone the vaccines, the antiviral pills, they're not there. So the first thing we're missing is we got to complete this job and make that capability available everywhere.
So Dr. Fauci just said you don't have the resources you need.
That's correct, and we've been going to Congress since the end of December, flagging that our money for being able to field a COVID task force that would enable delivery of that capability I just described, that funding ran out now
what have you asked them
ago.
for, and what did they give you?
Well, so we asked for a minimum of $5 billion just to keep the basic operations running. What came through is 0. So we're within.
That's a tweetable moment, if any of you are interested. And it's easy. People understand it.
And so, we are grinding our operations to a halt. The COVID task force will have to go away in the next couple of months. Now, hope springs eternal. We continue to ask for the funding to be there for COVID in order to enable delivery of the vaccines that protect people from deaths, enable bringing rapid diagnostic tests and antiviral pills through the world.
So whenever I sit down with Dr. Fauci, it's always extraordinary because you're basically sitting with someone who is the living encyclopedia of infectious disease in the world over the last 50 years, right? So it's extraordinary what he's done.
What he did in HIV alone before
HIV
COVID
is an extraordinary
is
story.
Remarkable.
So I guess I always worry about what will we be talking about 3 years from now, 5 years from now, and monkeypox is a new issue, and you're concerned about it. Tell us, as you look into the crystal ball where people are laughing about this, joking about it, not taking it seriously, what are we getting wrong as we look not only at that, but other potential pathogens that could come down the pike?
Yeah, so number one is to understand the world has changed in significant ways. Climate change is a big part of it. It is driving much more shifts, big shifts in where human beings live and where animals live, and it's creating new contact points between animals and humans where animal to human transmission of virus is turning up. Monkeypox is an example of that. Now, it is a painful rash, not at the deadly level that we would talk about with COVID, but how it mutates if it continues to spread around the world, and taking it seriously as something to stop is a critical part of the public health armamentarium. Even more importantly, we will have continued surges of outbreaks. Just in the last 3 months at USAID, we have dealt with an Ebola outbreak in the Democratic Republic of Congo. We have had a Lassa fever outbreak in Guinea, and just in the last week, Marburg virus, which is a 90% deadly virus, with 2 cases in Ghana. Stopping and controlling that capability is what we call global health security. It is pandemic preparedness. And investment to fight the fires now but prevent the fires later is a critical part of what we do. There actually has been bipartisan support for making some initial investments in those areas. Seeing that those continue are going to be absolutely essential. I'm going to tell you a good news story here. Ebola in 2014 to 2015, it was 4 months of circulating virus in West Africa before it was identified by physicians, diagnosed and notified with a rapid response created, now a slow response, right? 10,000 people died. In 2020, our investments at USAID, CDC, and others enabled the Democratic Republic of Congo to have an Ebola outbreak and recognize it within 15 days, mount a response, and therefore contained it to 55 deaths. In April, the last Ebola outbreak happened. And in fact, the number of outbreaks are escalating because of those contacts between humans and animals. And that outbreak had notification within 48 hours. They had the diagnostic kit at the hospital where the person presented with hemorrhagic fever. They tested them right away. They called out the outbreak. So within 48 hours, a response happened, contact tracing, vaccination, isolation. It's 5 deaths, and it's declared over as a local outbreak that could have been another global one. These are happening. Part of my job is these are happening on a weekly basis, these kinds of outbreaks, and making sure we have the systems in place to stop them is going to be critical to our future.
Let me ask you, I don't know if you remember, but the last time we were hanging out, we were hearing this fascinating presentation about data overlays and looking at zip codes, not just zip codes, but deep down in communities that was looking at social determinants of health, race, income, diversity, et cetera. And I always wondered if we could globally map that and not just look at the negatives, that what could we learn of looking at data and looking at, when it comes to community health outcomes, what are the ones that are getting it right doing? Are they just rich? Or are they, what are the factors that drive positive health? What are the factors that mattered in taking one of those bleak places in the world and turning it into a positive one? And so I know it's a New Yorker style question, but if you were to write that article about what lessons we need to heed and take seriously, knowing it's a triple lever dashboard, I mean, I sort of look at this as sometimes we need to know the bank shots that we have to get right that may not always be about a vaccine, but there may be other determinants that matter.
Yeah, this is critical. So, the zip code, the postal code analysis has shown that the same places that people are in the United States, dying of opioids are also the risk places for dying of COVID, are also the risk place for dying of heart disease. And there are a couple critical components that have turned up so far. Number one is the ability of the local government to mount a response to support people's needs. And second is the strength of primary health care. And that is a global story. The resilient workforce who are capable of addressing what the top needs are of a given community is your primary healthcare workforce. They are the ones who do the prevention, do the counseling, but then when vaccination needs to happen, they turn around with the vaccinations. I was in rural Ghana just a few weeks ago, and it's the same story I saw there that I saw in my hometown of rural Ohio growing up, which is that my mother was the second pediatrician for the entire community where we lived. And the story in Ghana is the same thing, that they had a malaria outbreak, they had COVID vaccinations to deliver, they had that rise in maternal and child deaths and needing to address acute malnutrition and so on. And it's the same people who do the work. It's the doctors, the nurses, the midwives, and the assistants who are either there or they're not there in those frontline clinics. They're either trained or they're not trained. They're either paid or they're not paid. And if they are salaried, if they are paid, they actually, you can be salaried and then your paycheck doesn't come. If they're trained, if they're actually supported with management and that connects people into a proper primary healthcare clinic, the reduction in mortality that Ghana achieved within 3 years was 50% for children. Within 7 years, a 70% reduction in mortality by working across that capability. We don't have that in the United States. We have more than a quarter of people who don't have a primary health care physician, another quarter who do, but aren't connected to them. And those are the people who get lost to the system, and that's the story the whole world wide over.
Let me finish with an easy question for you, Atul. Roe v. Wade. Roe v. Wade, in my view, I'm trying to process what the impact of it is, and I think one of the ways in which I look at some of the challenges we have in U.S. healthcare, but I think it's a global problem, is whether people feel like they have agency in that, whether they feel like they can prevail, drive their own decisions, become literate, challenge the healthcare community to perform better, or whether they're victims of the process. And I'm interested both in terms of your USAID work. Does that decision from the Supreme Court make a difference in the footprint of what you do in the world? And what do you as a person think this will do to the social contract between the individual and our healthcare system?
So the Supreme Court decision that repealed the right to abortion is important on multiple dimensions on that global scale. So first thing to emphasize is that the Biden administration remains absolutely committed to the sexual rights and sexual health of people and the reproductive rights and reproductive health of women. At USAID, funding to support abortion has been restricted for decades. So we actually have some experience with what happens when that funding might not be there. And what I would tell you is that the calls coming in and the meetings that I've had in the last few weeks has been concern about a couple of things. One is confusion, and we have a lot of experience with making really clear that if women come in who've had unsafe abortion, it's our job to be able to provide appropriate post-abortion care. Second of all, women having miscarriages or coming with bleeding, coming in with life-threatening issues. We need to be able to make sure that the health providers on the ground know that they have to care for those women, that it's a matter of life and death, and this is absolutely critical. We remain 100% committed to making sure that the right care is happening. Second is the fear that this is the beginning of taking away sexual privacy, taking away contraceptive rights. There's been decades of bipartisan support in the US that have made us the leading donor and supporter of distributing family planning capability around the world, and that is not going to stop.
Well, let me just finally say that I hope that you're keeping notes in a journal, as I would love to read your insights about how we can all do this better. And one of the most incredible writers on health in this country, Atul Gawande, Assistant Administrator for Global Health at USAID. Thank you so much, Atul.
Thank you, Steve.
Really appreciate it. Thank you.